Dr. Jiang, what is kind of the main thing clinicians could tell patients with trauma about preventing dissociation problems?
Mm-hmm. Well, I think in terms of I don't know that you can prevent dissociation issues with dissociation, because that's something that's going to be a pattern and a tendency that's set in place because of the trauma, whether they're a war veteran who's been traumatized as an adult or someone who carries a lot of developmental trauma from their childhood. Dissociation is a defense and also a process of traumatized remembering that happens when someone experiences something extreme, life-threatening, and too overwhelming to sort of have a stitched together way of remembering. And so what I would actually do with when patients are struggling with issues of dissociation is do psychoeducation and to normalize their experience, tell them that, this is something that they're not crazy, that this is something that happens to people who have experienced extreme or traumatizing events, and that it's something that we can work with and help them to understand and move forward from, or move forward with, alongside of.
Yeah. Now, what is a larger factor here? The type of trauma that the person experienced, or kind of other variables such as their family status, their job status, and overall health in other areas?
You mean like in terms of like, is it more their present situation that affects their symptoms, or is it things that have happened in their past?
Yes. Basically that, yes.
Yeah. I think that, it's a good question, and that I would say that it's both. Trauma, by its nature, by definition, involves things that have happened in the past, but that of course intersects with whatever's happening in the present. People can have triggers, people can be provoked into states of dissociation. People who have for example, people who have endured intense childhood abuse often have a tendency to dissociate, and are going to be prone towards using that pathway of regulating their own emotions, of disconnecting from their body, of losing memories and parts of themselves and things like that. And that tendency that was set in the past can be brought out by present events. You were mentioning COVID, actually, in that, present events, present stresses can bring out those stress reactive tendencies or traumatic tendencies in patients. One classic model is or one pathway that's more common is the sort of hypervigilance, the PTSD, the flashbacks, the quieter sort of presentation. Actually, 30% of PTSD patients present a dissociative type, but that's, I think, underappreciated, and that's the goal of our session, is to really highlight the quieter dissociative presentation of trauma. But it can be both. The past is important as it intersects with the stressors in the present.
Okay. Now, what is kind of the best type of therapy to help people deal with these issues?
Mm-hmm. I think that is a evolving and complicated question, but among the therapies that are very good include trauma-informed CBT, include EMDR, include emotionally focused therapy. A lot of the issues with dissociation are an inability or a lack of awareness into one's emotional states, or a defensive cutting off, splitting off of one's different emotional states. And so even a psychodynamic therapy that's focused on the emotions and the shifts in a person's emotional state can bring them awareness into the way in which they use dissociation. And with that awareness can come empowerment and healing. I think important across modalities, no matter what sort of therapy you're doing, empathy is incredibly important, that there's an open and safe experience of the therapist, that a real relationship is developed that is really healing, because people are not robots. They heal in social contexts. They heal in interpersonal contexts, in relationships. And so whether you're doing a CBT, a dynamic therapy, the therapeutic alliance, so to speak, or the connection with the therapist is huge.
Okay. Now, how often do these patients have comorbid other psych conditions, and how difficult is it to kind of handle multiple conditions at once for these patients?
Yeah. I would say that with trauma, comorbidity is more the rule than the exception. I would say that people often come in with meeting criteria for PTSD, for borderline personality disorder, for dissociative disorders, major depression, generalized anxiety. It's kind of like, how do you cut the cake? And trauma has been described as the lupus of psychiatry, meaning that it can kind of present as almost anything, really. And so, especially in a lot of developmental polytraumatized populations, which I think the community psych and clinics tend to work with. People who have adverse childhood experiences scores of over 4, which is like multiple numerous things and often ongoing things have happened, bad things have happened in childhood for them. Comorbidity is the rule. They come in with meeting criteria for a lot of stuff. And it is challenging, and it requires a multi pronged approach of both therapy and medication, if not other stuff. Yeah.
That was my next question. What medications have been effective treating this specific patient population?
Yeah. So SSRIs, of course, are very well understood to work for classic PTSD, and I think they are a solid first-line choice for complex versions of PTSD. In addition to that, addressing the hypervigilance, the sympathetic nervous system hyperarousal is very important, helping people to sleep. And so on that end, prazosin and trazodone, I like prazosin personally a little better, are very good for that, for helping people to sleep. I think that that's a particularly helpful choice among sleep aids, because trauma patients often get sleep aids, but that this actually targets the mechanistic issue at play, as opposed to just generally sedating someone and just putting them out. It actually targets the over-aroused fight or flight system. So I'm a big proponent of prazosin SSRIs, but in addition to that, there's like off-label use for second-generation antipsychotics, mirtazapine, among other medications. But those would be, I think, king.